Good afternoon, distinguished members of the Iranian Association of Orthodontists. Thank you very much for allowing me to make my presentation today. Today I want to talk to you about diagnosis and mechanics in clinical practice. I've been in orthodontic practice for 31 years and I'm going to share a little bit of my experience with you. So we're going to ask some questions. What defines facial balance in the sagittal plane? What causes facial balance to worsen in the Class II patient? How can we maintain or enhance facial balance in the Class II patient? Laverne Merrifield defined the profile line as a line from the soft tissue pagonion to the most procumbent lip. He defined the Z angle as the angle formed by the profile line and Frankfurt horizontal. Ideal is around 75 to 80 degrees. If we take a look at various profiles, we can see that this holds true for all ethnicities. We'll take a look at a few of these profiles here today. If we look at Nefertiti, who is considered beautiful in her day, we see that her face is very balanced. It's divided into equal thirds. The lower third is divided into 1/3 for the upper third and 2/3 for the lower third. If we look at her Z angle, she has a Z angle of 82 degrees. Here's an interesting picture from the Egyptians. Notice that they were all exactly 86 degrees. If we look at the Greeks and we look at Aphrodite, Aphrodite was 75 degrees. In Thailand, Buddha is depicted with a Z angle of 75 degrees. The chief of the tribe was 78 degrees. The Maoris chief, 85 degrees. If we look at the actors in Hollywood who were considered handsome and beautiful in their time, we see William Holden was 81 degrees. Betty Grable, 75 degrees. Elizabeth Taylor was considered the most beautiful woman in the world in her time. Notice the profile line touches both lips. The curl above and the curl below match at about 3 millimeters depth, and the profile line is through the middle of the nose, right at the anterior nares. That is the ideal, perfect profile for balance. Halle Berry, she's a black woman. The profile line comes in front of the nose. We cannot use the E-plane of Ricketts to evaluate all ethnicities because it was designed for Northern Caucasians. So the profile line comes in front of the nose, but the Z angle is 75. Angelina Jolie. Everybody likes nice big lips. They say, I want a nice full profile, so they want to expand and push the lips out. But if you take a look at Angelina Jolie, she has a very flat profile, 84, a very high Z angle. Lady Gaga, do you like this profile? Her Z angle is 57 degrees. It's been said that extraction causes narrow smiles, but the literature does not support that. It's been said that extractions equal bad smiles, but the literature does not support that either. So if we have a bad set of teeth with a bad smile, we want to fix it so our patients look happy. We do know that arch form tends to return toward the pre-treatment shape. Do we want to change it? Post-treatment, if we advance the mandibular incisors, they tend to rebound. So do we want to advance them? Expanded mandibular canines constrict after the removal of retention. There's probably no more issue that's been studied with regard to long-term stability than lower canine expansion. Our inability to permanently expand the lower inner canine dimension is one of the most rigorously documented facts. Anthony Gianelli. Muscle spindles. The resting length of a muscle is immutable. If you stretch a muscle, the muscle sends a signal to the spinal cord, which sends another signal back to the muscle telling it to contract. We cannot change the resting length of a muscle. So are we going to expand against these muscles? What will the muscle spindles do over time? What happens when you let go of the retainer? It's like letting go of the slingshot. So if we have crowding, we have two choices: increase arch length or reduce tooth mass. Which are we going to do? Well, we know that the arch length decreases from the mixed dentition to the adult dentition. So what does expansion do to the bone? In this study at the American Association of Orthodontists from the University of Oklahoma, they did a non-extraction treatment using the Damon system, and they evaluated it with a cone beam study. And what they found was that facial bone decreased significantly in height and in width. In this study, out of Denmark, the transverse expansion of self-lighting brackets was evaluated by cone beam. And expansion happened mostly in the canine and in the premolar region and was achieved by buccal tipping. No transverse augmentation of the bone was found. In this study by the Koreans, they evaluated alveolar bone loss following rapid maxillary expansion using cone beam tomography. Once again, the conclusion: rapid maxillary expansion may have detrimental effects on the supporting alveolar bone, since the thickness and height of the buccal alveolar bone decreased during the retention period. Another study in the American Journal of Orthodontics from about a year and a half ago was a three-dimensional assessment of buccal alveolar bone after rapid maxillary expansion and slow maxillary expansion. And what they found is there's buccal bone loss in both groups, but the slow expansion had more. So there are many who say, well, then we should use rapid palatal expansion because there's less bone loss. I would submit that we use no expansion because we don't want any bone loss. We want to keep the teeth in the middle of the bone for the long-term health and stability of the teeth. This study out of Istanbul showed that the Damon system provide comparable arch width expansion by tipping the teeth buccally with no significant difference in the amount of alveolar bone thickness. So just the expansion with the Damon system did nothing more than tip the teeth. So let's look at the aesthetic impact of extraction and non-extraction. This wonderful study by Jay Bowman and Lyle Johnston won the 2001 Angle Research Award. And what they did is they took a panel of 58 laypersons and 42 dentists, and they looked at 70 extraction and 50 non-extraction cases that were similar at the outset. And what they did is they measured the lips to the E-plane, and they found that the extraction patients were 1.8 millimeters flatter post-treatment than the non-extraction patients. But they found that both panels preferred the flatter faces. And they also found from both groups, the dentists and the lay people, that lips that were more protrusive than 2 to 3 millimeters behind the E-plane could potentially benefit from extractions and reducing the procumbency of the teeth. So malar and pogonial implants cannot compensate for vertical and horizontal expansion. Mother and daughter. Notice the difference in the facial features of the mother and daughter. She did not have expansion. She did. So do we want mentalis strain by expanding? Do we want the lower lip to stick out because the lower incisors are flared? So mechanotherapy can be good for the teeth and disastrous to the face. Let's take a look at this case. This young girl has a gummy smile, a long face, a receded chin. Notice the obtuse nasolabial angle. She really has no crowding. It's pretty close to a class 1 occlusion, a fairly simple case. Put some appliances on the teeth, line them up, and make an occlusion. So that's what we did. These pictures were taken the day of debanding. But look at the face. See how the smile is more gummy? See how her face is longer and the chin's more receded? Her face has been damaged. Well, let's look at why. She had a high mandibular plane angle of 35 degrees. So this tells us that the muscles are pulling obliquely to the mandible. to the body of the mandible instead of perpendicular to the body of the mandible in a low angle case. So there's no resistance to the eruption of teeth. So anything we do mechanically that's going to erupt the teeth will make the molars erupt. And if the molars erupt, the mandibles can't close down as far and it will hinge closed. It will rotate counterclockwise because she can't close down as far if the molars are erupting. Well, that's exactly what happened. If we superimpose the before and after cephalograms, we can see the mandible rotated down and back. And why? Molar eruption, molar eruption. Incisors came down, incisors stayed forward. So let's take a look at why. So if we put that first wire in, we can see that it goes into the molar and we tie it up to the incisors. And what are the forces? Well, obviously there's a force down on the incisor. Every action has an equal and opposite reaction. So there's a reaction extrusively on the molars. We get a moment around the anterior and a moment around the posterior. And that's what happens. And this is what happened in this patient. And that's why the mandible rotated down and back. Now, if we try it a little differently and change our mechanics, we put the wire in, we tie it up, we get the same reaction in the anterior, same reaction in the posterior, same moments, but we've banded every other tooth and we've got a nice stainless steel wire that's 18 by 25. Now, the thing that we do differently here is we put a high pull J-hook headgear to the anterior. That's going to give us a vector of force in this direction and an equal and opposite vector of force in that direction. That's going to give us a moment here, and all of these vectors are going to cancel each other out. This moment's going to cancel out. We're going to get extrusion in the bicuspid region, and we're going to get a moment in the posterior. So that second molar is going to upright. So now we band our first molar, we put a step bend in, we continue the headgear, we tie the wire in, we get moments around both of the molars, molars upright. Now we use a straight wire with a tip back to the second molar. We tie it in, we get moments around the molars again, we get a little intrusive force to the second molar, extrusive to the first molar. We upright the second molar. Now we make another wire with a compensation bend here and a tip back here. And we tip that first molar. Now we make a tip back bend to the second bicuspid with a compensation band so both of these teeth are passive. We get a moment here. And now we've got a nice level lower arch without extruding the molars. So let's make the teeth fit the face and not the face fit the teeth. Now here's a comparable case. This young girl's got a gummy smile. Let me move this over. This girl's got a gummy smile, a receded chin, and notice the fat lower lip here. See how that rolls out? Now if we take a look at the X-ray here, we can see that the lower incisors are very proclined. And if we look at the cephalogram, she's high mandibular plane angle, 35, just like the others. She's got a 5.5 degree A and B angle, bit class 2, a 63 degree Z angle. Lower incisors are at 101, 44 degrees relative to Frankfurt. We like to see them about 68. So these lower incisors are really flared. We look at the teeth. We can see the lower incisors getting pushed off the bone. We see crowding. So this case is a little more difficult than the other one. But look, the mandible did not rotate down and back. It came down and forward. The mandibular plane is still in the same direction. We have not opened the mandibular plane. The occlusal plane has closed and rotated counterclockwise. Molars have not erupted. Lower incisors have been uprighted. Upper incisors moved up and back. So look what happened. If we superimpose the before and after, we see we've uprighted the lower incisors And we've held that mandibular plane right where it is. And look at the difference in facial balance. Notice that lower lip's no longer sticking out, because the lower incisors, when they're flared out like that, it rolls that lower lip out. And the lower lip always looks fat. And when that happens, it tends to take the commissures down and it makes the patient look angry. So we upright those lower incisors and it balances out the lips, it balances out the face, it balances out the profile, and it makes balance and harmony. Upper incisors moved up and back from the high pull J-hook headgear. And the extractions, when you take the teeth out and you move the upper incisors back, the gingival display disappears. And here she is before and after and 4 years later. Notice that when you change a class 2 patient to a class 1 patient, they continue to grow as a class 1 patient, and we can see her Z angle actually increased post-treatment. So she got better, not worse. And here's her teeth at D-band, and here's her teeth 4 years later, and she wore no retainer. She came into the office 4 years later with her boyfriend because she wanted him to get his teeth straightened. I never saw her after her braces came off, and she said she never wore her retainers. So this is what we get. We get a supported, leveled lower arch. And we can see the difference between patient 1 with the mandible rotating down and back, molars erupting, and the difference in patient 2 with the molars held and the mandible coming downwards and forwards. So we have our choice. Do we want to use a supported lower arch or an unsupported lower arch, especially on these high angle cases? You decide. Well, let's talk about third order a little bit. Third order is a force in a rotational direction. It causes a torquing force on the tooth. If we take a look at the various third orders that are offered in the Ormco catalog, we can see that there's a tremendous range for each tooth. We see 11 degrees for the maxillary second bicuspid, and these ranges vary from around 10 to 15 degrees until we get up to the mandibular second bicuspid, and there's a range of third order of 22 degrees. This prescription says 0. This prescription says minus 22. There's a tremendous variation in third order in the brackets that you can buy. Who's right? Who has the magic third order? Well, let's take a look at some teeth. If we got 2 teeth that the long axis of the crown is going in the same direction, but they have a different labial morphology, look at the difference in the third order that's going to be achieved with the same wire with a bracket in the exact same position. If we have a young patient with a short clinical crown, we're going to put the bracket much more incisal. If we have an adult that has had some recession, we're going to be placing our brackets much more gingival. And look at the difference in third order. They're going opposite directions on the same tooth. Now, what about marginal ridge height? We know we want to finish our cases with the marginal ridges all the same height. So what if we have difference in the height of the marginal ridge relative to the incisal tip or occlusal tip of the tooth? These teeth have different distances from the marginal ridge, so the bracket's going to go on a different place, which is going to place it differently as far as the third order due to the labial morphology and curvature of that tooth. What if we don't get all the adhesive expressed from our bracket when we place the bracket? We're going to get a different third order. What about crown to root angulations? Well, we know we don't want to push the roots of our maxillary incisors against the cortical bone of the palatal shelf. That causes resorption. So we're not going to have the same third order on both of these teeth. Even though the crowns may look the same, we must be careful because we don't want to cause root resorption on these incisors. Now, bodily movement. If we want to move a tooth bodily, we need to have a force on the tooth and a moment. We need a moment to force ratio of about 8 in order to move a tooth bodily. Some say 12, depends on the tooth, but we need to have a moment to force ratio. Once that tooth has been moved, we need to remove the third order to eliminate the torque on that tooth. What if we want to intrude an incisor? We put a V-bend mesial to the cuspid. That's going to put an intrusive force, but that's also going to put a torquing force on that tooth. So we need to support that canine with a high pull headgear to keep it from extruding, and those forces will cancel. But then we need to put a lingual crown torque into our incisors so that those forces are eliminated. Then we'll get intrusion of the tooth. Now, what if we want to upright our lower incisors around the apex because we like our apical position? Well, we need to have a force and a torquing force to keep that root from moving backwards. So we want a higher than 8 moment to force ratio. Well, as that tooth uprights, it's not going to have as much torquing force, so we need to increase the twist on the wire to keep the torquing force the same. And once we get it to that position where the tooth is upright, we need to remove that torquing force. Well, what about the deviation angle? Okay, we have slop in the bracket to wire interface. And we can mathematically determine what that is. And you can see that when we plug those numbers into that mathematical formula, there's a tremendous amount of play in the wire. If we have a 19 by 25 wire, we've got about a 25-degree amount of slop, 12 and 0.6 degrees in either direction. So if we put 10 degrees of twist in our wire, or our bracket has 10 degrees, we're going to get no torquing force at all. We're not even going to get engagement. So let's take a look at a Class II Division I high-angle bimaxillary dental-alveolar protrusion. And here's how we like to treat it. We're going to take out the first bicuspids. Here's the case. Our first wire is going to be a 17 by 22 upper wire and an 18 by 25 lower wire. We will band every other tooth, and we'll use stainless steel resilient wire. By banding every other tooth, it doubles the length of wire between the teeth, and with the increased length of wire, we know that the force is inversely proportional to the third power of the length of the wire. So we get 1/8 the amount of force by doubling the distance between the brackets. So this first wire, we're going to put a high pull J-hook headgear to both canines. And we're going to start to retract the canines. And we're going to put a tip back bend on our second molars and start to upright them. Once we get them uprighted, we're going to band the second molars, and we're going to continue to tip, and we're going to continue to bring the canines back until we get the incisors aligned. We may need to step back to a round wire for some incisor alignment along this, and then move back to the original wire. Then we make our second set of wires, which is a 19 by 25 edgewise closing arch in the lower, and a 20 by 25 closing loop wire in the upper. We make a closing loop. It's 7.5 millimeters in height and 3 millimeters in width, and touching at the base. And we will activate this wire 1 millimeter each month. So it's going to take us about 6 to 8 months to get the spaces closed. We'll support it with a high pull headgear so we continue that counterclockwise force that we were talking about to prevent that clockwise rotation that those teeth want to cause. Notice in the back here, the distal of the closing loop, of the omega loop is 1 millimeter taller. So because if we have it at the same height, it's going to come down here when it's passive. We pull it in here, that extrudes this. So what we do as we close these, as we close this wire and it moves further forward, we reduce the height of this by increasing the cant of this loop. and dropping this distal leg down and removing the bend here to maintain that 15-degree tip. And once we get our spaces closed, we make another wire to tip back our first molar and our bicuspid, as we talked about earlier. Notice the compensation bend. So first we tip back this tooth, then we tip back this tooth and put in a compensation bend, and then we tip back this tooth and put in a compensation bend. We have a nice level lower wire. And I'm going to talk to you in a moment about learning more about this technique. We call this the 10-2 system because we're using 10 teeth as an anchor to move 2 teeth. First we do 10-2-7, we move the 7s. Then we do 10-2-6, we move the 6. And then we do 10-2-5, we upright the 5s. Okay. Here we do 10-2-7, 10-2-6, 10-2-5. After that, we make a full-size 21 by 28 stabilizing wire in the lower arch and a 20 by 25 working arch in the upper arch with a helical bulbous loop. And this is our Anchorage Preparation. Our helical bulbous loop wire we use to push back the second molar. And you can see the space being developed here. And here you can see the loop in here. It's 7.5 millimeters tall with a 3.5 millimeter helix. And we can see how that is pushing this back. We always wind to the lingual so it doesn't hit the flange of the bracket. And you can see how it's moving the second molar back. And we've already got all this space. So it's a 10-2 system. First we move the second molars back, and then we move the first molars back, and we sequentially move the teeth back. If the third molars are in the way, you must get them out. So here we are. You can see the space is now opened between the first and second molar. And now we solder a spur on the wire mesial, distal to the bicuspid. Then we add a spring between the spur and the first molar and a power chain, and we distalize the first molar. And we add a little tip to it to help it tip back as well. And you can see the space opening up as that moves back. And here we are. The space is all the way back, and now our first molar is now in class 1. Now we cut the spur off and file it down the solder, and we put a power chain. We take our spring and we move it forward between our hook, between our cuspid and our incisor, and we put a power chain on our bicuspid. So we're pulling on the bicuspid and pushing on the cuspid. And we do 2 teeth at a time here because it's the same as a molar is 3-rooted. This is a single-rooted tooth and a single-rooted tooth. It's about the same amount of root structure that we're moving. We wear class 2 elastics to our Anchorage prepared lower wire. Now if you notice, on our lower arch here, the elastics are pulling perpendicular to the long axis of the tooth. So that does not erupt the molars. If the molars are tipped forward and we wear a class 2 elastics, we're going to erupt the molars and we're going to cause the clockwise rotation of the mandible. So then once we move our bicuspid back, we finish moving the cuspid back into class 1. And then we make a closing arch like we did before. This is the wire after it's removed and after we have moved back the canines and everything distal to them. Now it's time to make a closing loop wire. And the set 4, we use the same mandibular wire and we make another closing loop like we did the first time. And we use high pull headgear to soldered hooks between the centrals and laterals. And we put soldered hooks between our cuspids and our bicuspids for vertical elastics to help support the anterior. We only wear the vertical elastics when we're wearing the headgear. And we continue with our class 2 elastics and we close the space. Now we make our final set of wires and we finish. And here's the finished case. Notice our posterior occlusion is open in the posterior. When we take the braces off, over the next three to 6 months, the teeth settle into a functionally dictated occlusion. We call this recovery. I'll talk more about that in a moment. Now let's take a look at this boy. Do you like this face? What do you think of this face? Do you like the strain that's caused here? The mentalis muscle strain, the gingival display, the convex profile. He has a hard time getting his lips closed. Notice his teeth have been damaged. Those are bonded because they were knocked and broken. When the teeth are protrusive like that, they're very likely to become destroyed. And you can see the damage to those incisors and how they were restored. You can see his occlusion is almost a full step class 2 on the right, kind of class 1-ish on the left, class 2-ish. Very protrusive, a little bit of crowding on the bottom, a little bit of crowding on top. Could we treat this non-extraction? Of course we could. Would it be to his advantage? No, it would not. So we took out 4 bicuspids on him. You can see he's got a high mandibular plane angle, 29 degrees. You can see the lower incisors are at 43 degrees to Frankfurt, 107 to the mandibular plane. He's got almost a 9-degree A and B angle, 6-degree widths. I'd call this a strong class 2 skeletal. In addition, he's got a 54-degree Z angle, very low. Interincisal angle is 102. He's got a 129 difficulty for craniofacial. Total space analysis difficulty, it's 14 in the anterior. He's got 4 millimeters of crowding. We need to upright the incisors 4 millimeters. And so that's going to take 4 on each side for 8 millimeters of space. So we got 12 millimeters of anterior discrepancy. The mid-arch, he's got about 2 millimeters of leeway space and a curve of spee of 2.5 millimeters in depth. So he's got a 0.5 millimeter deficiency in the mid-arch. He has 7 millimeters of class 2. You add the right side and left side together, the distance between the molar class 1 on each side. Then he's got a posterior discrepancy of 20. It's 26 millimeters. We can expect 6 millimeters of increase in the posterior. So his total difficulty for the space analysis is 33.5. He's got a total difficulty of 162, which is severe. Most cases run about 60. So here he is. We're in the middle of class 2 correction, and you can see the space opening in the second molars from the helical bulbous loop. And here he is when we're done. Mentalis strain has been reduced. The lips look better, gingival display has been eliminated, and he's got a nice straight profile. And here's his teeth. You can see the fractured teeth, which will be restored once he's old enough, 18, and we'll do some gingival recontouring for the difference in crown height for the 2 central incisors. And here's his teeth. See the tweed posterior occlusion? The second molars are out of occlusion. We can talk about that some more in a moment. And here's his teeth immediately on debanding. And you can see he now has a 75-degree Z angle. The A and B has been reduced to 3. FMA went from 29 to 25.8. So that was reduced a little bit. It wasn't opened. Interincisal angle went from 101 to 130. And we can see the mandible came forward. It came forward. We rotated his occlusal plane and his mandible counterclockwise. Molars have been held in place. They have not erupted at all. The upper incisors moved up and back. We uprighted the lower incisors. We had good cooperation, which helped. And we can see the difference in facial balance from before and after. Now, these models were taken 2.5 years later on the bottom. He quit wearing retainers, but he came in. I called him because I wanted to get some pictures and some models. And we can see the third molars are now coming in, but look at the second molar. See how those settled in? Look at the distal of the first molar and the mandibular second molar. Andrew's 6 keys to occlusion. One of the keys is the distal of the maxillary molar against the mandibular second molar. I can't create that, but functionally I can create that by creating a tweed occlusion and allowing those teeth to settle in to a position that's dictated by function, not by orthodontics. And on both sides, we can see the same thing over here. That second molar is now occluding with the third molar, distal. You've got our Andrew's 6 keys of occlusion. He's got a nice cuspid rise. Everything functions beautifully. And notice the before and after models. And we can see the changes that occurred pre-treatment, post-treatment, and then post-retention. He continued to grow as a class 1. Notice that lower lip came forward. The Z angle came from 75 to 78. Now both lips touch the line. It occurred with growth, and the curl of the upper lip and the curl of the lower lip match. Let's take a look at this girl. What are we going to do with her? She's got a little bit of crowding. We can see cephalometric, on her panorex. We've got a little bit of crowding, no room for the cuspid here, insufficient space here. She's got a big class 2, big overjet, 10 millimeter overjet. And we can see the Z angle is 65, FMIA is 57, and she's got a 6.5 degree A and B angle. So here's her pictures. Later, after we took out the bicuspids, we took out all 4 first bicuspids, and now here she is, and you see a lot of the crowding has been eliminated. The canines are coming in where the bicuspids were on both sides. You can see how this one is erupted distally into the space where the bicuspid was. So now all we need to do is to move the root, and we can see this is what happens. Now we put a Nance appliance in to prevent the maxillary molars from moving forward. But the mandibular molars we did not, which allowed them to move forward and helped us correct our class 2. So here she is at the end of treatment, and we can see we got nice root paralleling, and everything looks good on the panorex, and her teeth look into a nice occlusion. She's got a good class 1 occlusion and a nice profile. And we can see her cephalometrically. She's a 75 degree Z angle. The lower incisors are now 63 degrees relative to the Frankfurt horizontal. And A and B is 3 degrees. And here's her teeth. 2 years later, excuse me. I think it's 2 years later. And things are holding up well. You notice I have a permanent retainer in here. I leave those in for 5 years on cases where the lower canines were rotated to begin with. And we also do a circumferential, supracrustal, and transeptal fibrotomy on those teeth that are rotated. Notice the posterior occlusion. Once again, Andrew's key to occlusion here, the distal of the first molar against the mandibular second molar. As I stated before, I can't do that, but my tweed occlusion that I developed does. And here she is in her post-retention photographs. Before serial extraction, after serial extraction, after treatment, and then 2 years later. So let's talk a little bit about loops. We make loops for in our wires for aligning teeth. Loops allow additional wire between brackets. So if you've got teeth that are rotated or you've got occlusal gingival variations, we want to get them lined up, this is a very good way to do it. Vertical loops deflect labiolingually and mesiodistally. Horizontal loops deflect occlusal gingivally and labiolingually. Now we know that the force of a wire is inversely proportional to the third power of the length of the wire, as I mentioned earlier. So, if we make a loop, we increase the amount of wire between the teeth. That allows us to deflect it without changing the original arch form. As I mentioned earlier, the original arch form is what we want to treat to. I don't want to change it because I want long-term stability. The studies show us unequivocally that if we alter the original arch form, then we are compromising long-term stability. So here's the wire tied in, and here's another loop. Notice I've got two horizontal loops. And what I've got is to her original arch form. We make this arch card to fit the arch form. And here it is. This wire fits the original arch form. But I've got a rotation. Now if I put a nai-tai wire in here, I'm going to have extra wire going down and in here. And as that wire, as this tooth rotates out, that extra wire is expressed by flaring of the incisors. I don't want to do that. I want them to move distally if I create space. So here we are. We've got a little space that we've created. You can see that. We tie it in. And a month later, you can see what's happened in 1 month. Yet we have not expanded and we've not changed the arch form as we would have done had we put in a nai-tai wire. So if we make a horizontal loop with a helix, we add even more wire. That increases our flexibility. Now here's a case before and after 1 month of treatment. And you can see how that canine has moved into position and there's been no expansion and no change in the original arch form. Stoner box. This is a wonderful, the Stoner box is a wonderful loop to use for high canines. If you take a look here, we've mentioned about the force. Go through this again. This is how the Stoner box works. We have a bracket that's out of position. Say we have a high canine. We make a wire shaped like this with this box loop. It has 2 times the amount of horizontal wire between each tooth, so the force is 1/8 of what it is between the other brackets. That means that the force between these two teeth is 8 times stronger than the force between this tooth. So these teeth are going to have very little reaction to this. And that tooth's just going to come down like that. Very simple. So the box loop provides 1/8 the force to the affected bracket then applied to the adjacent brackets with a very low load deflection rate. This provides a continuous force applied over a long range of activation. Arch form is maintained and there's very little reaction to the adjacent teeth. Now if we tie in a nai-tai wire, look at what happens. We tie that in and it's going to create these forces. The force between here and here is identical as the force between here and here. So this tooth is going to react. And we're going to get a moment around both teeth adjacent to that canine. And as this tooth comes down, that extra wire is going to go both directions. Well, the posterior teeth are much less resistant to moving, so it's more likely that the anterior teeth are going to move and the arch form is going to be expanded. And this is what we get. This is what the box loops looks like. And here's a box loop tied in on the lower and one that's ready to be tied in on the upper. Now I have not tied it in this picture because I wanted you to see how I've increased it here to compensate for this. So we overcorrect the loop to get more of a moment on this canine. And we tie it in. Okay. Here's a box loop with an extra extension on it for higher up. Now this one I have a picture of after treatment at 1 month after and then 2 months. And you can see there's been no, it works very, very quickly and we were not getting any expansion or change of arch form as that tooth comes down. And we were able to torque that tooth very well to get that root uprighted. Now this is a nice little device that we came up with. I call the D Impactor. It looks like this. It's just a little wire that's 18 by 25. and we put it into our 18 by 25 auxiliary tube. I have a 22 slot on my main wire, but my auxiliary tube has an 18 by 25. But that's not really important. What is important is this has a little loop here, comes back like this, goes back to the first molar, or second molar rather, and then goes in approximately like floss. And then you cinch it back, pull it up, and it pushes the tooth back. This is after 1 month. We can see after 1 month that tooth is coming down. And here we are after 2 months. I'm able to get a band on that tooth, and I make what I call an auxiliary bypass. And I just take a wire, bend it like this, make a little lip here, come back, come down here, and I can put a little tip back here and move that root up and back. And I can bend this labially, lingually, occlusally, any way I want. I get that tooth in line. Then after I get that tooth in line, then I take the arch wire and I add additional wire and I relocate the omega. In this case, we cut the wire right here and I bend the end up. Then I take another piece of wire, add solder to it, bend its end up. Then I solder these two wires together. And then I locate where I'm going to put my omega loop. I bend my omega loop, and now I've got the wire going all the way back to the second molar. And I use the same arch wire. I don't bend a new one. And the advantage of that is that you don't end up affecting all the other teeth making a new wire. So we're not activating osteoblast and osteoclast in the process. We're just adding wire to that other tooth. And that tooth is already moving, and we can continue to move it. And you can see the tip back I have here for bringing that root forward. I also like to make soldered torquing springs because a lot of times you need to torque a tooth. In this case, you can see that this tooth needs to be torqued like this. So we'll solder a little torquing spring on here and have it push on the root back. And I'll put some twist in the wire this way, but if I just do it in the bracket, it's oftentimes not effective. And so, because the center of resistance and the center of rotation is not strong enough force to move that root back. And here's the helical bulbous loop I was mentioning earlier. You can see this a little closer. And here's the closing loop with the class 2 elastics after the helical bulbous loop. Notice we tie these tooth together with a nice twist, twist, twist with the Kuhn plier. I'm distalizing that canine. And here's the distalizing on the other side. Now we're class 1. All I got to do is make the closing loop. This is that wire again. I always heat treat the wires. You can use an oven, heat them up to 900 degrees Fahrenheit. I don't know the centigrade on that. And you can see the arch card that we make. And here's the closing arch. And here's it in place with the headgear. And this is torquing springs that I have for the canines. Oftentimes when you have palatally impacted canines and you bring the canines out, the canines have a labiolingual inclination to them, as you can see here. And so we soldered little torquing springs on here and over here. It's just a little piece of 18 round wire, and we push on the incisal and we put twist in the wire, lingual crown torque into the wire for that tooth. And then in a couple of months' time, we have those canines in a much better position. Here's an example of torquing springs for the maxillary incisors. Just putting the twist in the wire never seems to be as effective as you would like it to be. So it's real helpful to use these soldered torquing springs. Here's another torquing spring. And you can see this is afterwards. This tooth has actually been torqued maybe a little too much. So I want to invite you all to come to Tucson, Arizona to take the Tweed course to learn these techniques. This is the oldest continuing education course given in dentistry or medicine in the world. It began in 1935 with Dr. Tweed, who was the hand-picked successor from Edward Angle. People clamored to his office to find out how he was able to achieve the results he did. There were so many people coming to his office that he decided to start putting on a course. This course has been given every year since 1935, except during World War II. We give this course 3 times a year. It is a wonderful course. It's very famous. It's booked up about 2 years in advance. I strongly encourage all of you to try to come out to Tucson and take this course and learn how we do things. Thank you very much.